Mac, are you there?
You want to give it?
All
Yeah,
right,
you want to give the
perfect.
ground rules,
Having a
Todd?
little trouble- There we go. Yeah, so just like last time, the way this is going to work is that we're going to Mac's going to present a case. We're going to have some invited discussants who are going to chime in, but we want to invite the audience to really participate in this. We want chat discussion. You're invited to call in discussion. We will post that link and that link is there. So if you want to participate. So Mac, go ahead and start us off with the first case.
Let's have the first slide. All right, next. So our case this evening is a 12-year-old male who's brought to the emergency department as a level 2 trauma. He's been a restrained front seat passenger vehicle crash going about 50 miles per hour. Mildly tachycardic, but otherwise hemodynamically acceptable. And your initial A, B, C, D, E's are also acceptable. Glasgow Coma scale is 15. The neck is not tender. There is some bruising on the chest and the abdomen consistent with a seatbelt sign. And there is some left upper quadrant abdominal tenderness that's moderate. Next. A chest x-ray shows a moderate left pulmonary contusion. And the ED resident tells you that the left upper quadrant has some fluid, as does the pelvis on FAST exam. So the question for the audience is, what do you order next? Do you get a complete abdominal ultrasound because you're trying to avoid a CT scan? Do you get a CT scan of the abdomen and pelvis with IV contrast? A CT scan abdomen, pelvis, and chest with IV contrast? CT scan abdomen, pelvis, and neck with IV contrast? Or a CT scan of everything? Maybe throw the head in too, because you just don't know. So as we wait for people to vote, let's see in our discussant room, Dr. Stylianos, could you make a comment about how much radiation should we be giving our trauma patients?
Well, with the typical pediatric mechanisms, I think limiting the radiation would be very key. I think we could accomplish a lot with ultrasound. I say that to preface my comments. This is not the typical pediatric mechanism. High-speed collision with a fatality, bruising in areas that create a lot of concern. And so I'm afraid that this child is going to undergo a fair number of rapid CT components, most likely, depending on if the chest x-ray is read as a widened mediastinum, the chest and the abdomen and the pelvis. So I'm going against my usual because of the mechanism.
Do we have any chat room, Todd? Do we have any comments?
Well, we have one comment. It says, unfortunately, in the chat room, it just says their first name, but it's David. I don't know, David, right, who your last name is, but David says, never trust the ED resident. But what's interesting is the polling is that the highest answer is CT abdomen alone, CT abdomen pelvis, no chest, but the second highest is also getting the chest. The rest are all tiny little percentages.
David, comment about the FAST ED resident? Dr. Notrica.
Sorry, who are you asking?
Dr. Notrica.
Oh, okay. So, so it's interesting. So, fast ultrasound has a role in unstable trauma. I think that that when you apply it to stable trauma patients, you get a lot of experience doing fast ultrasounds. I don't know that it's part of the management algorithm for what you do with that kid. So, if the patient's stable, then at that point, you have to decide what your priorities are. So I don't think that in a stable patient, I think you've presented me a stable patient. I think at that point you need to look to see whether or not you need a CT scan. So PCARN gives us some good guidance on who needs a CT scan, and one of the things that is an indication is if you have abdominal bruising, seat melt marks, you need a CT scan of the abdomen. And the percentage hit on that is very, very high. So you're going to find a lot of injuries, and you're going to find a significant number of injuries that actually need surgical intervention. So, yeah, I would go to get a CT scan of the abdomen. I don't think that I don't know that you need to fast in order to make that decision.
Okay, thank you. And Regan, I saw your head going up and down about a CT at least of some sort, right?
Yes, yeah, I kind of agree with both of them. The PCARN study would show that we need a CT of the abdomen for sure, but also the blunt abdominal trauma study that the PSRC did a couple years ago would suggest actually that maybe we need more information because they took into account labs as well, and you didn't give us any labs yet. So maybe we need more information to make the real decision.
Okay. All right, Todd, any other comments from the audience?
Yeah, I mean, it's kind of all over the place, Mac. You know, you got some people saying no need for chest CT. Some people saying, let me start with abdomen. Some people saying bruising CT with the seatbelt sign. Some people saying you do need a chest CT to rule out contusions because you saw chest bruising. And so some people saying, no, you do not need to get a chest CT. David writes, CTA of the chest of clinical evidence of great vessel injury. What is that? This is, let's see. Yes, chest also after physical exam. So all over the place.
All right, the next slide, please, Steve. So you get your abdominal CT scan, abdomen and pelvis.
Let's see.
And your CT scan shows a grade 4 splenic laceration with moderate hemoperitoneum. The patient is stable after one appropriate IV fluid bolus. So your plan at this point, given that CT scan finding, would be consider angioembolization, go to the OR for laparotomy, admit to the intensive care unit for bed rest and Q6 hour crits, admit to floor with bed rest and Q6 hour crits, or admit to the floor planning to get one more crit in 6 hours, but allow activity and diet. And if it's stable in 6 hours, stop. Regan, you want to start with the comment about grade 4 splenic lacerations and what sort of guidelines do we need to be staring at?
Sure. So we updated the APSA guidelines last year for solid organ injury and presented at APSA. And for this patient, some significant things we tried to do was to take the original guidelines, which Dr. Stylianos did 20 years ago, and then all of the great work that Atomic has done with Dr. Notrica over the last 20 years, and mesh those together into a updated guideline. So the basis of the updated guideline really is that we don't manage things by grade of injury anymore, but really by clinical factors. So for this patient, if they're stable, they wouldn't require ICU admission. Also, we definitely don't need to do angioembolization because they're stable and wouldn't need to do laparotomy. And then we did try to limit the amount of labs that are gotten on the patient now. So the patient would really only require one more lab. And if the hemoglobin was stable and there are no other signs of ongoing bleeding, then they wouldn't need any other labs. So this is a great example of the new guidelines and how we took 20 years of work by the two people sitting here with me and tried to make things a little bit better for our patients.
David and Steve, are you happy with the new guidelines?
Yeah. I'll defer to Steve.
Todd, any comments?
I mean, you all agree? That's no fun. I mean, come on.
I want Steve to comment first, and then
The godfather of guidelines.
Right. So first of all, just being on this panel, I appreciate sticking around for these 20 years, and I thank Regan, who really did so much work to put together something that made sense and something that was easy to digest. So really a brilliant job. Now, what we needed 20 years ago was not to take better care of children with splenic injury. They were all doing pretty well. we just needed some conformity, and it was fun to do, and it was received very, very well, and it had a pretty, good run. But as we noted, others had noted that grade by itself was not what was necessary. Grade still predicts what's going to happen to the child. And that was shown by David's work with the Atomic Plus. That grade still predicts what's going to happen. It's helpful for counseling. It's helpful for teaching. But the clinical scenario is very, very important. And the one thing that I wanted to re-emphasize about Atomic is about 5 times as much information as the old APSA guidelines. The old APSA guidelines were about stable patients, and that was it. And David and his group took it to a much bigger, broader level and was very valuable. It's just cumbersome to digest, and that was the only mark against it. I think Regan did a great service with her team by taking everything that was out there and making it digestible again. So, yeah, well done to both of you.
David, you want to follow up quickly and then we'll move ahead?
Yeah, so, if it wasn't for the work that Steve Stylianos started, I don't think we ever would have had the fundamental grounding to even do the work that Atomic did. And let me just be clear, Atomic wasn't just my work. There were a lot of surgeons who really contributed, and Sam Smith kind of gave us the idea that we needed to look at this again, and Sean St. Peter chipped in some amazing studies, and it's a group effort. So it's not just David Notrica. It's a lot of people. Everybody on the Atomic Plus group really contributed. And Steve's comments about the Atomic guideline being too large and too bulky is absolutely right. Matter of fact, we're working to simplify it down, we were getting hematocrits too much. We don't need that anymore. We have evidence to suggest that, and that wasn't available at the time. And so when I look at this Q6 hour H&H's, I kind of cringe. I'm like, oh, you don't, yeah, it doesn't need that. But yeah, I'm really pleased with the work that Regan and the Atomic and the APSA Trauma Committee did, and I'm happy with the direction that we're going. We're not there yet, but we're really
Great,
going
thanks.
well.
Todd, can you give us a result update?
Yeah. So what do you think? What do you think 70% of the audience said?
See,
I'm making an uncomfortable pause here because I want you guys to guess. Anyone on the panel, what do you think?
I think they probably went with C, even though D is the answer.
They went with C. There's 70% of the people. Now, here's an interesting thing, though, and they brought up a good point that not all ICUs and floors are the same at all different institutions or different countries or different cities. Depending on what your institution can handle, the right choice may need to be made. So that was several times people have made that point. Comments on that? And then, by the way, if any of the callers are there, go ahead and yell out.
Todd, when some of the work began on this evidence-based or consensus-based work, it was very sobering to find out that only about 20% of children with splenic injuries were treated at pediatric trauma centers. And so, those people who helped develop the guidelines and those people who implemented the guidelines were treating the minority of children in the country. So since then, we've been able to get those guidelines out and get some benchmarks in the American College of Surgeons trauma verification process. But the bottom line is a lot of these children are in places where, like you have heard, the floor is close to a hospital. So they may need to go to an ICU, not because anything great is going to happen there, but that's really the only right environment for that child. So that's why we have to take the 70%, and look at where the respondents are coming from and in what setting they have.
Oh, that's a great question, and we should be able to do that after the fact.